talk about wrist flexor and extensor and tendon repair. I'm Jessica Castro.
I'm Kira.
I'm Tavian.
So the objective for this presentation is that students will understand the principles and concept of the wrist flexor and extensor repair surgery. They're also going to be able to understand the indications of the procedure. They will learn about precautions before and after the surgery, and students will be able to understand the contraindications before and after the procedure. Y'all will learn more about the methods of this type of surgery, and we're going to be able to understand the rehab process for this type of repair. So,
can we y'all upload it into Canvas?
not yet. You want to see? Yeah, yes, sorry, yes.
You want us to pause and do it now? All right.
Oh my God. So, as we know, tendons are fibrous connective tissue connecting muscle to bones. We're focusing on the primary types with our extensors and flexors. The tendon repair is a type of surgery that fixes damaged or torn tendons. Movement can be extremely limited when tendons are torn or damaged. The affected area may feel weak and cause pain to the affected person. The tendon repair surgery may be helpful for people with tendon injuries that make it difficult to move a joint or are very painful. Of course, if a patient is presented with a toral rupture, is gonna need surgery. The surgeon will extend the wound or make an incision if there is no wound to locate the damaged tendons. This involves making an incision in the wrist, hand, or finger so they can locate the ends of the divided tendon and stitch them together. Extensor tendons are easier to reach, so repairing them are a little bit easier to fix. Then the surgeon will start the process of repairing the tendons, and the wound in the hand will be closed with stitches, and a rigid splint will be applied to protect the repaired tendons. A simple flexor tendon repair takes around 45 minutes to an hour, but complex surgery for more severe injuries will take much longer.
Okay, so indications for flexor tendon surgery. There are different zones, but we're not going to go into all of those because that would take forever. So just in general, indications for surgery would be those with complete tendon injuries, those with more than 50% of the tendon, if it's more than 50% of the tendon isn't injured, and if the injured tendon is pulled apart. Okay. Indications for extensor tendon surgery is basically the same, but we add if they cannot extend the fingers, and it also has a bunch of zones here, and it adds the conservative approach was not effective. All right, precautions. These are after surgery, and it kind of depends on which zone you're in as well, but in general, the flexion is a lot simpler. So no active flexion of the surgical fingers after the surgery, no passive wrist extension of finger extension, and they cannot use the hand or functional activities for 3 weeks after the surgery. And then for an extensor tendon repair, we talk about some zones here. The DIP is kept in 10 to 15 degrees of hyperextension for zones 1 and 2. There's no active DIP motion for 6 weeks, also in zone 1 and 2. The PIP joint is kept at 0 degrees to prevent extensor lag in zones 3 and 4. And to avoid making a fist is in zones 5 and 6. No resistance until 6 to 8 weeks post-op in zone 5 and 6, and no active wrist extension or resistance until week 4 in zone 7.
So the contraindications, as we know with surgery, it is important about the healing process. And these are all things that could affect the healing process, so such as uncontrolled infection, severe vascular insufficiency, uncontrolled diabetes, rheumatoid arthritis, things that cause things to swell and inflame, could make the tendons pull back apart. So we don't want to go into surgery if these things are present. Methods of procedures, so flexion, tendon repair. Patient is supine with arm placed on an arm board. You get general anesthesia, apply tourniquet to stop the blood flow. An incision is made along the path of the injured tendon. Now, there are many procedures that can be done. I also want to add, it's important to know when you're working with your patient as to what procedure they may have done, or ask the doctor, ask them, they may know, because that could impact your prognosis and the outcomes that you look to reach. So for the modified Kistler technique, I will go to this one because it's most common. There's a bit that is longitudinal at the site. It is transverse bit from one side of the tendon to the other. I don't really know how to really show you, but if you have the tendons here, you're going to, these are the two tendons. You're making an incision at the site. It's gonna come out, and then you're gonna go over the ventral aspect of the tendon, and then do the same thing on the other tendon, pulling it together. You do about 4 to 6 knots. This will help keep the tendons from being too flared out, because if it's too flared, they'll pull back apart. So this is probably the best technique. Some say that it's more invasive, it takes longer to heal. And the other techniques are Strickland technique, loop lock technique. And for the extensor tendon repair, same thing, patient supine, placed on the arm board. The technique you may commonly see is the grasping core suture technique, 2-strand 1 knot sliding mattress technique. Basically, there's a couple knots that are taken between the two tendons. It's a little different than the other one because obviously that was a flexor repair. But this technique is most often used. You have the figure 8 of suture and the running lock suture.
Now for the rehab process for the extensors, it's a little bit long because each zone has their own rehab process. So for zone 1 and 2, for day 1 to week 6 or 8, we're gonna start with active PIP flexion of the affected finger with adjacent fingers held in extension. For week 6 or 8 will be a gentle active PIP extension and flexion. We're gonna start at 10 degrees of flexion, and from there we're gonna progress the patient more per week. And for week 10, we have fine motor activity, increased flexion gradually while maintaining PIP extension. For zone 3, for day 1 to week 6, we have active PIP flexion of the affected finger. And for week 6, we have the therapist will start gentle active PIP extension to 30 degrees of flexion, and PIP extension will be maintained. Also, the therapist will begin with lag activity without the orthosis if there's no lag of extension. And for week 10 is going to be the discharge of the orthosis. Now for zone 4, it's going to start with day 3 to week 4. For the central slip, we're going to place the MCP in the slightly flexion with active PIP and DIP flexion. And for the lateral band, it's going to be basically the same, just the wrist is going to be placed in 30 degrees of flexion. For week 6, gradually the patient will stop the use of orthosis during the day for light functional activities such as typing, writing, dressing, or eating. For week 10, we're gonna initiate the progressive resistive exercises. For zone 5, the therapist will start working on active range of motion and passive range of motion to the MCP, PIP, and DIP joints and orthosis. Then for week 4, we're gonna have gentle active range of motion exercises. And for week 6, we're gonna have progressive use of hand for ADLs and IADLs. For zone 4 to 7 with control motion. For zone 5 and 6, we're gonna have active MCP flexion with PIP and DIP extended, then active MCP extension with PIP and DIP in a hook position. Active extension and flexion with orthosis on as well, with passive PIP extension and active PIP blocking. For zone 7, their orthosis will be removed just for exercises that the patient will be performing. And we're gonna have some active wrist flexion and extension at 20 degrees with some hold. For zone 4 and 6, if there's no extensive lag, the therapist will remove the wrist orthosis for active wrist flexion and extension. And then we're gonna have, if there's no lag for both, like flexion and extension, and the patient can achieve full wrist and finger motion before removing the orthosis, therapists will start with light ADLs activities, and then they're gonna be progress to IADLs. And then for week 6, we're gonna start the orthosis and focus more on the ADLs and IADLs exercises.
Alright, for zone 5 and 6, till the 4th week, you can do active MCP flexion, PIPs, and DIP extension. You do active MCP extension with PIPs and DIPs in the hook position, and then initiate active full fist and composite wrist flexion with fist at week 5. And at week 10, you can do passive range of motion, light fine motor, and light fine motor activity. Alright, for zone 7 through 8, day 5 to 4 weeks, you can do active hook fist and full fist, passive wrist extension from 40 to 20 degrees, active wrist flexion 20 degrees with fingers actively extended, and at week 4 you can begin wrist active range of motion. And at week 6 you can do passive range of motion and light fine motor activity. Alright, and then this is the thumb. So zone T1 to 2, day 1 to 6 weeks, you can do active range of motion, 25 to 30 degrees of short arcs of motion to the DIP and MCP, 35 to 40 degrees of flexion to DIP and MCP. Week 6 to 8, you can do gentle active IP flexion to 10 degrees, place and hold thumb and extension, gradually increase active IP flexion. And then week 8 to 12, you can start light pinching and grasping. And then zone T3 to 4, day 5 to 2 weeks, you got 30 degrees to 40 degrees of active IP flexion and 0 degrees of hyperextension. Week 2 to 5, active MCP flexion up to 25 degrees with IP and 0 degrees. And then week 5 to 8, full active MCP and IP flexion, isolated and combined. And then you can start fine motor activities. T3 to 4, day 5 to 2 weeks, actively flex IP in 30 to 40 degrees and passive extension 0 degrees. And then week 2 to 4, you can do active range of motion and extension. Week 5 to 8, full active combined and isolated flexion, and then progressive resistance exercises.
So as Kira stated, the T zone is a radial thumb side. So T5, day 5 to 5 weeks. You have IP active flexion 6 degrees within orthosis. Thumb MCP joint passively flexed 30 and extended. Progress passive exercise by 10 more to wrist and thumb. Begin active thumb opposition. Week 5 to 6, active thumb opposition to base of small finger. Then week 5, 8, passive range of motion, pinching, gripping with light resistance. Zone 1, week 1 to 3, hold fisting in all 3 positions using minimal tension. Patient may perform all exercises at home, this is good. Active tendon gliding, week 4 in all 3 fist positions. Week 5, gentle DIP flexion, blocking exercises for the flexor digitorum profundus gliding. Week 6, gentle passive DIP extension exercises if needed. Week 8, resistive exercises progress gradually.
This is the rehab process for the flexors.
Right. Zone 2 to 5, week 0 to 3, we're gonna remove the splint. You can start some passive wrist extension with fingers flexed. Passive wrist flexion with passive hook fisting to prevent intrinsic tightness. Week 3, place hold for hook, full and straight fist with wrist extended. Week 4, initiate active, non-resistive digital flexion and extension in all 3 fist positions with wrist extended. Week 5, add gentle blocking exercise for DIP, PIP flexion if needed. Week Week 6 may initiate NMES, therapeutic heat, via ultrasound if needed. Week 8, functional use of hand, gradually add resisted exercise to home exercise.
So as an overview, we know that a tendon repair is a surgical procedure used to restore the damaged or torn tendons. When tendons are injured, movement can become severely restricted, often leading to weakness in the affected area and persistent pain. Inadequate active and passive flexion of the digits indicate flexor or extensor tendon repair. Precautions include keeping the hand immobilized for a certain amount of time and having a slow progression to active range of motion and passive range of motion. There are different surgical procedures such as the modified Kessler technique and grasping cord technique. The rehab process is divided by zones and exercise focus on extension, flexion of the DIP, PIP, MCP, dorsal, and palmar side of the hand. For the last phase therapists focus on functional activities. That way the patient can return to regular activities. Those are our references. Any questions?
Liz.
So like, can there be like a reoccurrence of tears or anything even after the surgery? So like, how like common would it be based on the type of surgery?
So I don't know how common it is, but I would say it could happen if you don't keep with the after surgery protocol of keeping it immobilized for a certain period of time. What's up, Gabby?
What's the difference between ADLs and IADLs?
ADLs are more like activities of daily living, and IADLs are more like instrumental activities of daily living. So ADLs are more like specific self-care tasks, like bathing, walking, eating, stuff like that. And then IADLs are more like complex tasks that require more like a cognitive function, more like if they are shopping for groceries, using the phone, driving, and stuff like that.
Why is the figure 8 suture used in zones 4 through 7?
That zone is very delicate as far as it needs a lot of extensibility. So that suture isn't very invasive as far as really strengthening. When I say that, as strength dominant when doing that technique, because it does need a lot of flexion extensibility in that zone. Any more questions? Thank you.
Right, I have a comment to make. So, thank y'all for taking your time going through the protocol, the rehab protocol. It's expensive because you got all these different zones and regions when doing wrist flexion and extensor tendon repairs. And so you kind of have to do your rehab considering zone by zone. So I'm glad y'all took your time to go through that, because as therapists, we would really have to have those sheets in front of us to make sure that we're following those protocols zone by zone. And those are the protocols that most surgeons are gonna ask you to follow after they do a wrist flexion and extension tendon repair. All right, thank you. And with y'all repairs, did y'all get those like verbatim from protocol?
Yeah.
Yeah.
Okay, that's what I need to know.
It is in the reference.
Okay, good job.